Thank you for that very kind introduction. I would say after 20 some odd years now of being a physician, I still struggle to say glomerular, but I blame that on myself towards the roots. So I completely agree with you. I won't point out that Dr. Falk just walked out of my talk, so try not to be offended by it. At least you want to know what I've messed up. So these are my disclosures. I do have some consulting to disclose there. So as an outline for this talk, I really struggled with trying to figure out what to talk about for this because happily, there's a lot to talk about. I think if we had to give this talk 10 years ago, there wouldn't be much to say about what's new, nor would we really know where we were headed. And so as I'll show you, there's been a lot of progress in this disease space over the last several years. So I'd like to talk a little bit today about how our approaches to disease management have evolved in the last couple of years. Talking about how we've reassessed how we use our older therapies, a little bit about some of the new therapies, which Dr. Warzikowski will cover in more detail later this afternoon, and then where we're going in future therapeutic directions. Again, mostly alluding to that, and Dr. Free, I think, will talk about some of the really amazing stuff that we may be able to hopefully get to in the next few years to really turn off the disease. And then Dr. Falk talked about the long-term remission off therapy patients that we have. And so I do want to talk a little bit about that and if we can identify who those patients are and when the right time to stop treatment is. And as a little bit of a departure from that, one other piece I thought would be interesting to discuss would be some new approaches to studying what's a rare disease. So I think one of the biggest problems as we do research is that you need numbers. And so if you have a very rare disease, it's very hard to take a measure and see if there's a difference between two groups if the groups are really small. So can we do other, can we have other approaches that would allow us to really understand what measurable differences might be by finding more patients and putting them all together? And then the last piece is not really research driven, but I thought it would be important to talk a little about the importance of collaborative care. So meaning how we help take care of patients as a group. So not just your nephrologist or your rheumatologist, but both of them working together, our pulmonologists, our ENT doctors, and you'll get to hear from some of those folks today as well. But really what we've tried to push for is that multidisciplinary approach so that, you know, you get comprehensive care and all of your providers are on the same page so you don't have doctors changing medicines left and right and not knowing what to expect. So before we talk about what's new, I thought we'd talk about what's old. So predating, you know, our understanding of this disease and the identification of antibodies driving this disease, we knew it was an autoimmune disease process. And our former standard approach really was two drugs, steroids and a medicine called cyclophosphamide. So steroids, everyone hates, but the wonderful thing about them is they work really quickly. So when you have someone presenting with a really acute illness, they turn off the immune response pretty quickly. So that's still a mainstay of therapy, although we're hoping to move away from that. Cyclophosphamide is a drug we borrowed from the oncologists. So this was a chemotherapeutic drug. And the way it really works is to kill off cells that are reproducing rapidly. And so your immune cells are part of that response. And that drug seemed like a good thing to try to get this disease under control. And with the absence of really any known therapies or better understanding the disease, even when patients got into remission decades ago, their remission therapy was continuing on cyclophosphamide, just a lower dose. And to me, this is the kind of taking a sledgehammer to a nut to crack it open. So we don't really know what else to do. We take the biggest thing we can and just really try to knock it down. And so these are really non-specific therapies that have a lot of potential for toxicity. What's exciting is, as I mentioned, there's been a lot of work in this field and clinical trials that have shown us how to better manage patients with therapies that are somewhat more specific. And I'm not going to go through all of these because I think this would take us probably several days to do so. But really, this is over about a 20-year span, the clinical trials that have focused on vasculitis, or specifically ANCA vasculitis, these last 20 years. And what I'll point out is really within the last 5 or 6 trials are all within the last 5 years. And so there's been a lot more momentum in how we approach patients. So we've gone from using just cyclophosphamide to understanding we can use less immunosuppressive therapies for maintenance therapy. We have the availability of rituximab, a drug that turns off antibody production, we think, to some degree, to use both as a remission therapy and then. And we're learning that, you know, that may be a drug that is important for remission for a lot of patients. What I'm going to focus on are these last 3 trials up here. and just really briefly talk about how they've changed, partly because the focus of those has been looking at how we manage steroid therapy in patients. I think Brandon talked a little bit about this, and I'm sure more of you have understood this better than I have, but steroids and vasculitis as a mainstay of therapy come with lots of toxicities. And so if we look at some of the clinical trials from Europe, this is 270 patients across 4 clinical trials. They looked at those patients 5 years after they completed participation in the trials, and there was an increase in the number of patients who had hypertension, osteoporosis, diabetes, cataracts, all of these things that are associated with steroid therapy. And one of the measures that we do use in clinical trials now is something called the Vasculitis Damage Index. And I think what's really unique about vasculitis is that as researchers have begun to study this and really talk to you as patients, they learn, the measures we look for aren't always the most important to you, but how you feel is important. And so what's included in the Vasculitis Damage Index is not just how your disease is behaving, but whether you've had problems related to therapies you take. And as you can see, the major ones here are diabetes, osteoporosis, hypertension, cataracts. Those are all steroid-related therapies. So as we've learned over the years, our high doses of steroids may not have been necessary, and we've slowly tried to learn how to scale that back. When we look at our data here from UNC, and this is a lot of our patients, and I think some of you included probably, looking at patients who were able to come down off of their steroid therapy after about 6 months comparing to those who stayed on therapy. Those patients who stayed on therapy longer were about 1.5 times more likely to have infections, and they tended to have a greater risk of diabetes. But there was no difference in relapse rates or end-stage kidney disease, or the measures that we think as clinicians are important. So really, kind of looking at that and taking the understanding that maybe we don't need to keep people on steroids as long. And that's really shaped our practice over the last 15 or 20 years now, is to really look at trying to get most of our patients off of corticosteroid therapy, which was sort of heresy years ago and now becoming more conventional practice. One of the trials I mentioned was something called the PEXIVAS trial. So this was a trial that was actually initially focused on looking at plasma exchange in vasculitis. So patients who presented with really severe disease using a procedure called plasma exchange. That's a bit like dialysis, where we artificially remove the antibodies that we think are causing the disease in the hope that that would help get the disease under control faster. Generally, this has been reserved for patients with the most severe approach because it's a pretty aggressive, invasive therapy. And there's always been controversy among providers as to whether it really provides benefit. I'm not going to go into a whole lot of that. We can maybe talk about it later in some of the breakout sessions. But the other part of this trial that was really interesting was that in parallel, they also had a portion of the trial where they looked at using a reduced steroid regimen. So rather than giving the conventional high-dose steroids and keeping patients on steroids for that whole period of time, they built an arm into the study where patients would also either get this lower steroid therapy or remain on what was considered standard therapy, standard of care at that time. And at 6 months, the patients in that lower dose group had about 60% less steroid use. There's no difference among the measures we keep following: end-stage kidney disease, death, or keeping patients in remission, despite being on that less steroid dose. Importantly, there were fewer infections seen in the reduced dose group. I will say one of the features of this that I think we've been trying to understand better is that in the patients who got only rituximab induction therapy upfront with steroids, there was a tendency maybe for greater relapse in patients who were in that lower steroid group. So perhaps if you just use rituximab, maybe you might need to be on steroids a little bit longer. That's again evolving, and when we talk about numbers again, this is one of the largest trials in vasculitis, in ANCA vasculitis, that's ever been done, and had about 700 and so patients. And in that group, interestingly, only about 15% of the patients got rituximab. So it's a much smaller group of patients to look at. And as you'll see, that's probably changed as time's gone on. The low-VAS study was a study that came out of Japan, and it's a little bit of a different approach, but again, a reduced dose arm. These included patients who didn't have severe disease, so a little bit different than the PEXIVAS group. And they were able to demonstrate that they had less new onset diabetes, fewer infections, in using that reduced dose steroid group. So really, as therapy has evolved now in these last couple of years, and every major society that puts out guidelines on how to manage vasculitis have now incorporated these reduced steroid regimens into what we advise providers to use to treat patients with vasculitis. This final study I alluded to earlier was, and Dr. Falk talked a little about, is a new therapy that has focused on complement. This is the newest therapy approved for vasculitis. And complement are these little tiny blue dots that are up on the field. And this is a component of your immune system that's sort of always available and ready to work. And so it can act rapidly to fight off infections. But here in the setting of vasculitis, works very rapidly both to start the disease injury process and then keep it going by recruiting all these inflammatory cells to cause injury. And for many years, it was not clear that complement was involved in vasculitis, although there has been demonstration from Dr. Falk and Dr. Jeanette's work in animal models that complement is an important part of the disease. And when we look at patients, there are groups of patients who actually demonstrate low complement levels in the blood, suggesting that their complement is being used up. And those patients tend to have slightly worse disease. Dr. Falk mentioned this mouse model, and so there's been a longstanding MPO mouse model of vasculitis available here through Dr. Jeanette and Dr. Falk's work. And in this mouse model, they were able to demonstrate that if you block this component of C5a, which is part of your complement cascade, you're able to reduce kidney disease in the ANCA model. And you'll see here these little bars going down the screen. As you give higher doses of this drug, which then was called CCX168, you were able to reduce the amount of kidney injury that we saw. This led, this I think to me is one of the neatest things that you see really of what we described as bench to bedside therapy. So over several years later, we have the Advocate study, which looked at this drug now called Avocopan, where patients are given 30 milligrams twice a day of Avocopan with a much severely reduced steroid therapy compared to conventional steroid therapy. And in the trial, we saw similar rates of remission out at 6 months, and then maybe even better rates of remission out at a full year. And there was a lower risk of relapse. One thing to point out, though, is even though we were hopeful this would be a completely steroid-sparing agent, about a third, patients who were on Avocopan still got about a third amount of the steroids that the patients who did not get Avocopan. So as of now, we're still trying to understand exactly how to use this drug, but it is still used in combination with steroids up front. What about maintenance therapy? So once we get patients into remission, we start wondering, how long should we keep them on therapy? How long do they need to receive this? And that's a question I think comes back to us a lot. And the guidelines on this are kind of all over the place. And so KDIGO, which is one of the big kidney disease guideline entities out there, has focused, with rituximab, and we'll talk about that primarily, as that's the, I think the conventional maintenance therapy for a lot of patients now. But they recommend, continuing on this 500 milligrams, 2 doses of rituximab after you achieve remission, and then giving it again every 6 months for at least 18 months. And they make a very vague statement that you can continue that out as long as 4 years. And then we really don't know what to do. And that's based on the trial data that shows that you can keep patients on therapy for 4 years and they have lower rates of relapse. But also when you look at some of those patients who didn't go into those longer term treatment arms, only about a third of them relapse. So 2/3 of patients could get away without getting remission therapy. So do we really understand when we should stop therapy? And the answer is not yet, but we're hopefully getting there. There is another schema that was used for treating patients for remission called the Rituximab study. And they were very aggressive in the rituximab dosing they were using. So they were giving a full gram of rituximab, but giving it every 4 months. And partly because that study focused on patients who had relapsing disease, so they're a little bit harder to treat. So I think when they designed the study, they wanted to be really sure that they kept patients under control. And so these are the 2 regimens we see used more often. We lean towards that first one. The American College of Rheumatology has kind of similar guidelines that, suggesting maintenance therapy for at least 18 months, and maybe longer depending on patient-specific factors. That's about as detailed as it gets, though, because I think then it's left to the patient and the treating doctor to kind of decide, do you have the features we're concerned about that would put you at higher risk for relapse? So going back to this idea of long-term remission off therapy, so this is, to me, I think one of the most powerful things about engaging as patients is that these are all the data that have come from our clinics and our patients that we followed over the years. And this was a group of 400 patients. And so I mentioned to you, these vasculitis clinical trials are ranging between 200 and 700 patients. We have 400 patients here that are just part of our network of patients that you guys make up. And when we looked at this group of patients, we had about a little more than half of the patients who were able to come off of all treatment. And we were trying to understand what makes them different. And so within this group, females were more commonly than males able to come off treatment. Those patients who got higher doses of the IV pulse steroids we give at the start of treatment were more likely to come off of all treatment later on. And what we saw is those patients who did stop treatment had fewer relapses. And how we interpret this data is a little bit biased, right? Because this isn't a trial, this is just what we see happening. And so we don't know at the individual level of every patient what makes that person say, we're going to stop treatment and see how you do and watch you very closely. What features that person may have aren't necessarily what we're trying to understand better. More importantly, just from what we're looking at clinically, and Dr. Free will talk a little bit about today, I hope, is what we know about patients who've come off treatment and what's different about their immune system. So we know that with vasculitis, you lose this ability to tolerate yourself, right? So this idea of self-tolerance is gone, where you're reacting to your own body's proteins and triggering this disease process. And we can still find detectable antibodies in patients who were on long-term remission off treatment, but there doesn't seem to be a response to those. And trying to understand what makes those patients different provides us with a basis for potential therapies down the road, and whether we can reintroduce that ability to tolerate your own body and not react to it from an immunologic standpoint. So what's on the horizon? I came across this slide as I was going through a million papers this week trying to figure out what to talk about. And it sort of gave me a headache when I looked at it. It made me think of like when Tom and Jerry used to get in these fights, and Jerry would make these gigantic, like amazing devices to drop a ball on Tom's head. That's kind of what it looks like. But what we've, I think taking from this, what we know is that the biology of this disease is incredibly complicated, and we've learned a lot more about it over the years. And all these different features where we see this loss of tolerance, where you suddenly recognize your own proteins as being foreign and triggering that disease process, where you continue to have B cells that eventually grow up to be the plasma cells that make antibodies to this disease. Why do those keep proliferating when they shouldn't be reacting to your own body? And at the acute level, the neutrophils that we think induce a lot of this injury, like what makes them active and primed and ready to go. So understanding all those pieces provide us with different targets for therapy, but also probably different targets for therapy at different times in the disease. So we think, this neutrophil idea, the idea of neutrophils being very activated, so cells that would typically be fighting off bacteria, causing injury to your blood vessels, they're really predominant up front, but the driving force behind that disease is still this abnormal antibody and the proliferation of those cells that are making those antibodies, and how do we turn off that process and put out the fire at the same time. And so staging different therapies across the disease lifetime is probably important. So as we've moved away from our sledgehammer, we've moved away to a group of other tools that are still pretty crude but different, and give us a little bit more specificity than we have now. But the hope is that we would be able to get to more targeted treatments that have less toxicity, more specificity. And can we use these agents to better reduce the disease that causes this autoantibody production? Can we turn off the autoantibody response and the reactivity to those antibodies? And can we find ways to identify patients who no longer need immunosuppression? I think that's a big focus, because it becomes sometimes easy to say, we'll just keep you on immunosuppression because no one has to think about it then. You keep coming in for your infusions and everybody feels great. But over time, we know that there's complications associated with that. So how do we get to a point where we can identify when a patient's ready to stop therapy? So what's on the horizon? This is, I think, the slide that Dr. Falk's probably going to be most disappointed in me. He said to me, show them all the trials and show them what they do. And there's too many trials, so I can't do that. But what I can say is what's great is that there are so many trials, and they're really focusing on different portions of the disease. So we've moved away from trying to use these big drugs that completely knock out your immune system to trying to use drugs that refine that response and turn off those proliferating cells that shouldn't be continuing to respond, trying to induce tolerance. This idea of cellular therapies and CAR T cells, which Dr. Free will talk about later, is exciting. With a lot of caution, I think we have excitement about that. but it's pretty interesting. So moving away from this, like how do we study rare disease? As I mentioned, it's very difficult to study patients and measure differences when you don't have many patients. And the PEXIVAS study, which was one of the largest studies in that study, it's about 700 patients. Our question is, can we utilize other resources to look at different practice patterns and see if we can identify how patients respond based upon what we do? And one of the folks in our group, Carolyn Thorpe, who's a pharmacoepidemiologist in the School of Pharmacy, has done a lot of work using insurance claims data. And granted, these are messy because this is always what gets put down on a piece of paper and may not actually be what's going on with the patient, but they've gotten pretty good at refining it fairly well to show that these diagnostic codes that we use do correlate fairly well with vasculitis. And so she's looked over a 3-year period of Medicare data. So again, this is restricted to the Medicare population, but identified almost 30,000 patients with vasculitis, of whom had a new, what we think would be a new diagnosis in that period of time, about 15,000 patients who got new immunosuppressive therapy in that period of time. And I'm not going to go a whole lot into this, but really the idea here is that, can we use, national data sets to identify large numbers of patients and then ask questions in there. The difficulty with insurance claims data is that we have the drug that patients receive and big outcomes that are diagnostic outcomes. We don't have lab values. We don't have, whether they had lung hemorrhage. We don't have the finer details that we really want to know. And our hope is that we can take that and all of the electronic medical record data, now that we're all forced to use computers instead of paper, which has probably slowed me down in clinic by 4 hours. But all that electronic medical record data, it's great because it's a ton of data. And so now I think our hope is that we can merge those claims data, take hospital record data, and really try to fill in those gaps. And it won't be at the level of following patients individually over time, but it gives us big numbers to be able to ask some relatively basic questions, but still important ones that we haven't been able to do so far. As I mentioned, I was going to talk a little bit about collaborative care in vasculitis. And so, this has been the focus for us the last couple of years and something Dr. Falk had pushed for a long time, and we had done piecemeal for a while. The idea of multidisciplinary care. And so we know in vasculitis and autoimmune disease, when patients, when there are multidisciplinary clinics available, it shortens the time to diagnosis and probably allows for selection of better therapies for patients. It may allow for more equitable care. We see that a lot of patients who live further away from specialty centers have difficulty getting in to see an individual specialist. But these kinds of bigger clinics where you have multiple specialists plugged together can sometimes help overcome that. And I think importantly, it allows for shared ownership of managing patients. I call Dr. Orzechowski at least twice a week to ask her what I should do for a patient. And we spend about 10 minutes and we usually agree on a plan. And I'm thankful she thinks like me. It makes me feel like I know what I'm doing. But the idea is that, rather than going to see your rheumatologist and them telling you to say, oh, you need to stay on your steroids for 6 months, and you see your nephrologist who says, oh, you should have stopped your steroids a month ago, finding that right balance so that you get the right message is important. And so, I think as part of that, we talked about how there is a delay to the diagnosis of vasculitis. If you look at the diseases I've talked about today, GPA and MPA, it takes about 6 months before a patient is actually diagnosed with onset of their disease. And some of that is related to the time, how far away they live from the healthcare site, whether they're still working and just can't get to the doctor often enough, whether it's hard to get to a specialist, whether they've been misdiagnosed with something else. And the hope is that, by having these multidisciplinary clinics, we can reduce that delay. The other reason I think that they're important is that the patients we see are really different. So this is a study that's looked at vasculitis patients, both in nephrology and rheumatology clinics where they're separated and comparing the two. And as you can see, the nephrology clinic patient group is a little bit older. They tend to have more severe disease and obviously have more kidney disease, so their creatinine levels are higher. They tend to have higher titer antibodies, and they tend to have more disease activity. And so that doesn't mean that we're better taking care of really sick patients, but patients don't get to us until they are really sick. And so our rheumatology colleagues are much better at managing some of the rumbling severity and some of the off kidney effects that we see related to both disease and therapies. So how we've done this here at UNC, we established this multidisciplinary clinic about 3 years ago, 2 years, something like that. And the way we tried to model this clinic is we have our rheumatologist, Dr. Orzechowski, Dr. Mike Cunningham, our group of nephrologists, is a whole bunch of us, a pulmonologist, and at one point we had a dermatologist who we're hoping we'll get another one again. But we're able to see everybody together as a group. So you come to one clinic visit, you see all your doctors, and you get one message as to what to do when you go home. So there's less confusion from bouncing from one place to place. And the great part of that, at least from my end, is that it's one visit for you. So you don't have to go through 15 different visits to get to all these people. This really happened because we built this gigantic, we meaning not me, but the hospital system, built this gigantic clinic building where all of our subspecialty clinics are piled into one building. And so our hallway turns into the rheumatology clinic as you walk down the hallway. And so we have overlapping rooms and we're able to just kind of put our heads together and talk in real time rather than having to wait and find the time to catch up after some patients. So just as a quick summary, management of vasculitis, we have refined over the years, but we're still using pretty broadly immunosuppressive drugs. And our hope is that we continue to refine that so we can use drugs that are more specific and less toxic. We're using a lot less steroids. And we have new therapies that are coming out and hopefully will come out. But we're all still learning how to best use them because anytime something new is presented, completely changes how we approach a disease, and we still have to figure out how to get comfortable with doing that and knowing the right patients to use the drug in. And then our patients who are in remission off therapy, this is a really valuable group of people to learn from because we can learn a lot about their immunologic status and the clinical factors that would keep them off treatment and learn how to apply that to other patients. We have a lot of emerging therapies, as I mentioned. We're hoping these future therapies will help reestablish self-tolerance. And we're hopeful that these large data sources I described will give us some additional guidance on what therapies work best and how to refine our approaches even better. And lastly, just as a plug again for collaboration between specialists, I think that's a huge and important part. So I'll stop there. Thank you guys for your attention.